Endoscopic retrograde cholangiopancreatography, ERCP, is considered to be one of the most challenging procedures in gastrointestinal endoscopy. In order to attain competence in performing this procedure, extensive training is necessary. Trainees differ considerably in the rates at which they acquire their endoscopy skills. Moreover, methods of measuring ERCP competence are lacking and poorly defined. At present, competence is merely assumed on the basis of performance of a minimum number of ERCP procedures, ranging in various training programs mostly from 100 to 200. The American Society for Gastrointestinal Endoscopy, ASGE, recognized that 180 through 200 ERCPs were required for competence based on the first study regarding this subject. This important study used a composite endpoint for procedure success and evaluated a relatively small number of procedures per trainee, average 85, with only 3 trainees reaching the level of 180 procedures. The evaluation of trainee performance was carried out by trainers. Additional data are scarce and threshold numbers do not necessarily reflect competence. Various guidelines state that competence should be verified by objective performance criteria. Outcome measures such as common bile duct, CBD, cannulation rates, and therapeutic success give insight into performance. The ASGE guidelines state that a trainee should be able to reach an 80% through 85% CBD cannulation success rate at the end of ERCP training. There is, however, no standardized method to assess such criteria. Continuous self-assessment may be one way to gain insight into the performance of trainees. This method has already proven its value for competence measurement in colonoscopy. Background and study aim. Measures for competence in endoscopic retrograde cholangiopancreatography, ERCP, during training are poorly defined. Currently, various training and accreditation programs base verification of competence on performance of a minimum number of procedures. There is a general awareness that procedural competence certification should be based on objective performance criteria. Continuous self-assessment using a Rotterdam assessment form for ERCP, RAFE, can provide insight into trainee performance. The study aim was to express development in ERCP competence as a learning curve. Methods. ERCP trainees at a tertiary referral center in the Netherlands were invited to participate. Performed procedures were appraised using RAFE. Indication for each ERCP and presence of a virgin papilla were documented. Complexity was graded on a 3-point scale. The primary outcome parameter was common bile duct CBD cannulation success rate. Success of the intended therapeutic intervention was additionally expressed as a learning curve. Results. 15 trainees were included. 1,541 ERCPs, 624 procedures in native papillary anatomy were assessed through RAFE. Unassisted CBD cannulation success rate improved at 36% at baseline to 85 after 200 procedures, and in 624 patients with the virgin papilla from 22% at baseline to 68% after 180 procedures. Learning curves for therapeutic interventions showed significant improvements for successful sphincterotomy and stent placement. Conclusions. Learning curves are a valuable means for assessing competence in ERCP. Differences in learning curves can be shown with RAFE. Verification of competence should be based on actual performance instead of minimum numbers.